Good morning, everybody. I hope you're all doing very well. Thank you so much for giving me the opportunity today to be able to speak at Grand Rounds. I understand that I'm one of the first people to speak at Grand Rounds in this academic year, so really wanted to welcome all of our new interns, residents, and fellows, and I really hope that you guys are all enjoying Miami so far. So my name is Shelley Wang, one of the pediatric neurosurgeons at Nicklaus Children's Hospital, and a bulk of my practice involves functional pediatric neurosurgery. So I wanted to talk today about the evolution of pediatric neurosurgery and pediatric specifically epilepsy surgery in Miami over a 30-year period during one of the retrospective reviews that we have performed recently. Thank you very much for allowing me this opportunity. So as you may know, epilepsy is a pretty common pediatric neurologic condition. Its prevalence is estimated to be about 3.2 to 5.5 per 1,000 people, and approximately 30% of patients continue to have seizures despite appropriate trials of two or more appropriately chosen and tolerated anti-seizure medications. And these people are considered to be drug resistant or have drug resistant epilepsy or medically refractory epilepsy. Children and teenagers with medically refractory epilepsy experience greater mortality in addition to increased risk for poor neurocognitive and psychosocial outcomes, alongside a lower quality of life. And epilepsy surgery may result in seizure freedom or improvement in the quality of life. However, it remains underutilized as only about 30% of candidates undergo surgical intervention. Furthermore, epilepsy surgery referrals frequently occur following trials of multiple anti-seizure medications, and the median delay, according to a study from seizure onset to surgery, ranges between 30 months to about 5 years. When patients do undergo phase one evaluation for epilepsy, pre-surgical evaluations include video EEG, neuropsychological evaluation, consultation, radiography, and sometimes ESI, MEG, or TMS. Electrographic clinical and radiographic correlation helps us to select an ideal surgical candidate. And epilepsy surgery provides greater freedom from seizures than continued medical treatment and results in reduction of seizure control or a reduction of seizure frequency and in patients with medically refractory epilepsy patients. And a recently published randomized controlled trial of medical versus surgical management in epilepsy coming out of India and AIMS demonstrated superior seizure control, neurocognitive, and quality of life outcomes in the surgical cohort. So what is our understanding of the role of epilepsy surgery in adults? A lot of our information is coming out of one of two randomized controlled trials, in addition to multiple case control trials and retrospective reviews. However, this is probably one of the greatest landmarks in the benefit of epilepsy surgery in adults. There's 80 patients in the study, 80 patients with temporal lobe epilepsy were randomly assigned to surgery or treatment with anti-seizure medications, so 40 in each cohort. And optimal medical therapy and primary outcomes were assessed by epileptologists who were unaware of the patient's treatment assignment. And the primary outcome in this study, published in the New England Journal of Medicine 20 years ago now, was freedom from seizures that impair awareness of self and surroundings. And secondary outcomes were frequency and severity of seizures, quality of life, disability, and death. And what we saw in the results of this study was that at 1 year, the cumulative proportion of patients who were free of seizures impairing awareness were 58% in the surgical group and 8% in the medical group. And this is statistically significant. And the patients in the surgical group had fewer seizures impairing awareness and had a significant better quality of life. And again, statistically significant with a p-value less than 0.001 in both components compared to the medical group. And 4 patients had adverse effects of surgery, whereas 1 patient had in the medical group had died. And the conclusion from this landmark paper published 20 years ago now is that in temporal lobe epilepsy, surgery is superior to prolonged medical therapy, and the randomized trials of surgery for epilepsy are feasible and appear to yield pretty precise estimates of treatment effects. Later on, we see another randomized controlled trial published in New England Journal of Medicine, this time out of India, as I had mentioned previously, in 2017. This is a randomized controlled trial of patients who undergo appropriate epilepsy surgery and medical management, and 116 children now who were under 18 years of age with drug-resistant epilepsy did undergo either neurologic surgery appropriate for the underlying cause of the epilepsy, along with appropriate medical therapy, or they were randomized to receive medical therapy alone. And the patients in the medical therapy group were assigned to a waiting list for surgery. And the primary outcome was seizure freedom at 12 months after the start of the study. And what we saw is that there were pretty serious adverse events in about 33% of the surgical group. However, what you can see is that the surgical group achieved much higher chances of seizure freedom at 1 year after surgery versus medical therapy alone. And again, this was the first randomized controlled trial of epilepsy surgery versus medications for the pediatric population. And this worked to advance our knowledge and understanding of the benefits of epilepsy surgery in the pediatric community. Now, as just a brief background, patients with epilepsy may undergo what we call a phase 1 evaluation, which consists of an MRI, video scalp EEG, and neuropsychological evaluation. And then really what happens after that is that there are two challenges that really come into play. First of all, we want to better localize the seizure onset zone, so where exactly the seizures are coming from. And second of all, we want to diminish the risks of postoperative neurologic deficits. So specifically, patients with, we want to decrease the chances of language, motor, sensory, visual, and memory deficits. So with all of these coming into play, we do a variety of different types of testing for them, including MRI, functional MRI, electrical source imaging, SPECT, PET, in addition to the video EEG and the neuropsychological evaluation. In patients with no reasonable hypothesis about localization of seizure onset zone, or those who have an unfavorable ratio between risk and postoperative deficit, are managed by either anti-seizure medications alone, sometimes with ketogenic diet, sometimes with a vagus nerve stimulator. And those are usually the kids who are not candidates for epilepsy, intracranial epilepsy surgery. However, some kids may undergo a phase 2 evaluation with intracranial EEG in order to better localize the seizure onset zone or to perform functional mapping. And some children go on to get epilepsy surgery without a phase 2 evaluation if there is a localization of the seizure onset zone. This is the general course of evaluation for a patient for most epilepsy centers in epilepsy centers. Okay. And Nicklaus Children's Hospital, which is formerly known as Miami Children's Hospital, has had a very strong tertiary epilepsy program since the 1970s. And we're considered a level 4 epilepsy program. And this program was really one of the first pediatric epilepsy programs in the country to perform different types of surgeries, including implantation of subdural grids, MR-guided LIT, MR-guided focused ultrasound, and much more. And really over the past 30 years since the start of this program in the 1970s, epilepsy surgery has really evolved significantly. So in order to have a more contemporary cohort, we looked at the cohort over the past 30 years. It was specifically between 1988 to 2018 to allow us about 2 years of post-surgical assessment for ANGLE outcomes. And the objectives of this study was, number one, to describe the patient demographic, imaging, and electrophysiologic characteristics of a surgical cohort who have undergone surgery over the past 30 years. Number two, to discuss the pre-surgical evaluation, surgical technique, and case mix. And then number three, to discuss the evolution of the surgical selection, patient demographics, and outcomes over time. In this study, it's a single center retrospective review of consecutive surgical epilepsy cases, evaluating pediatric cases of epilepsy surgery. And it's a 30-year period, as I mentioned, between 1988 and 2018. And this was dichotomized into early versus late eras, the early eras consisting of 15 years between 1988 and 2003, and the late eras consisting of, again, 15 years of evaluations between 2004 and 2018. Surgeries of both curative and palliative intent were included in this study, and the patient demographic, clinical, radiographic, and surgical information was evaluated. Furthermore, trends in surgical cohort and case mix was assessed, and 2-year seizure outcomes by Engel classification was also evaluated. So as you can see here, for the 30-year period, approximately 1,240 consecutive epilepsy surgery cases were performed over this 30-year period. However, adults who were 19 years or older were excluded from the study, and that consisted of approximately a 9.1% or 113 surgical cases. Those patients were eliminated from this analysis, and therefore 1,127 independent surgical records were reviewed for pediatric patients who did undergo epilepsy surgery. When we dichotomized it into one of the two cohorts, there were 453 cases in the early cohort between 1980 and 2003, and 674 cases in the late cohort between 2004 and 2018. What we saw is that, as you can see from those numbers, there's been a 50% increase in the surgical volume over the past 15 years. And what interestingly we found was that the mean age of surgical seizure onset in addition to surgery have both statistically increased. The entire surgical cohort consisted of about 55% males and 45% females, and the mean age of surgical onset was 3.9 years. However, it was statistically higher in the late era, and the mean age of seizure onset was 4.5 years in the late era versus 3.0 years in the early era. The mean age at seizure surgery was 9.6 years, which was also statistically higher in the late era at 10.3 years versus 8.7 years in the early era. When we look at the number and proportion of repeat cases, so patients who are undergoing surgery when they have already had a previous epilepsy surgery, we realize that the number of redo cases have significantly increased in the late era compared to the early era. And those redo cases either come from our own institution or more commonly from patients who were initially operated on in an outside institution. And it's increased significantly in recent years and consists of approximately 16.4% in the later cohort. And in general, patients who did undergo repeat surgeries for epilepsy were older at the time of surgical intervention, so 10.8 years versus 9.5 years, and also experienced seizures for a longer period of time. So I'll talk about this data in a little bit, but it does point towards our surgical case mix being more and more complicated over a period of time, and us as a tertiary epilepsy level 4 center having more complicated cases, either who have previously underwent surgery at outside institutions, or sometimes those who have discordant electrographic or radiographic findings that make them more complicated patients. When we look at the radiographic findings and the substrates of patients that we have operated on, we see an interesting pattern. So first of all, radiographic findings on the MRI were classified into 4 categories. Number 1, focal lesions. Number 2, broad malformations. Number 3, cerebral insults. And number 4, MRI negative. And what do we mean by focal lesions? They include either developmental or other neoplasms, focal cortical dysplasia or FCD, or hippocampal sclerosis. And this was really the most common radiographic finding, consisting of about 63% of the surgical cohort. Broad malformations include diffuse polymicrogyria, hemimegaloencephaly, lissencephaly, schizencephaly, hemispheric malformations associated with Church-Weber syndrome, or other congenital anomalies. Cerebral insult included focal or diffuse stroke, hypoxic ischemic injury, and prophylaxis as a result of hemorrhage, infection, or traumatic brain injury. And lastly, patients were considered to be MRI negative if they displayed a normal MRI or one with incidental findings not associated with epilepsy development. What we saw was that in both eras, the patients with lesions consisted of the bulk and the majority of our substrates. And the distributions of surgeries in these four categories really remain quite stable despite significant advances in radiographic and other technologies over the 30-year period. But the distribution of surgeries between these four categories remain quite stable between the early and late eras of the study, with focal lesions comprising the majority, or about 63% of cases in both periods. And despite advances in imaging over the past 30 years, there's really been no significant difference in the MRI findings of the surgical cohort who underwent epilepsy surgery over these two eras. When we look at the surgical case mix over a 30-year period, what we found is a gradual trend for less volume of surgical resection, and also, of course, the introduction of new and interesting different types of neuromodulation in recent years. So this is the case mix of patients who underwent surgeries over the 30-year period by early or late era. And over this 30-year period, the most frequently performed surgical procedures were resections that followed a two-stage implantation, lobectomies, and focal open resective surgeries. And over time, there was a significant shift from extensive surgeries like hemispherectomies and lobectomies, or temporal occipital parietal disconnections, which are multilobar resections, towards more limited and tailored resections. For example, over this 30-year period, there were 132 cases of hemispherectomies, and hemispherectomies comprise of approximately 12% of the entire surgical cohort. However, they have been proportionately fewer in the late era compared to the early era. So only about 63 cases in the late era versus 69 cases in the early era, which was statistically significantly fewer. Similarly, lobectomies, for example, frontal lobectomies or temporal lobectomies, or sometimes multi-lobar resections or disconnections, comprise about 18% of the entire surgical cohort, but was also proportionately fewer in the late era compared to the early era. So 16% in the late era versus 21% in the early era, which was significantly significant. And in contrast, when we look at the late era, our program performed much more focal resections, which included lesionectomies, corticectomies, and sometimes MR-guided laser interstitial thermotherapy ablations. And in total, 610 cases of focal resections were performed, consisting of about 54% of the entire cohort, and it was proportionately more in the late era compared to the early era. We have a very small, minuscule number of gamma knife radiosurgeries or MRI focused ultrasound for central brain lesions leading to seizures, including hypothalamic hamartomas. And this accounted for a very minuscule proportion of the total surgical volume. I will talk a little bit about MR-guided focused ultrasound because I think it is something that's very interesting that we've started doing approximately a few years ago. However, I think this as a proportion of the overall number of epilepsy surgeries still remain very few. When we look at the number of palliative procedures, the conglomerate of corpus callosotomies and neuromodulation techniques comprise of about 11% of the entire surgical cohort, and it's remained the same between the two eras. However, not surprisingly, in the later era, there's been a greater number of neuromodulation techniques of palliative intent, including VNS and RNS implantation, and a subsequent decline in the number of corpus callosotomies. I do want to focus a little bit about phase 2 evaluations before we go on to talking about more of the newer surgical techniques. And I just want to touch on this a little bit. Although implantation surgeries, which are phase 2 evaluations, or intracranial EEG implantations, were not considered independent surgeries in this study, we did evaluate their trends over a period of time, because the number of implantations were quite significant in our study, and they comprise of about half of all surgeries in the early cohort and a third of surgeries in the later cohort. And these numbers coming from our institution do parallel the findings from a multi-center study published in 2008, which was a survey of 20 pediatric centers. The survey indicated that approximately 2/3 of children did proceed to resection without did proceed to resection and required only non-invasive evaluation. Oftentimes because they had an MRI lesion with concordant semiology and scalp electrophysiology. However, 90% of centers did report using intracranial EEG in about 30% of patients. And this is quite congruent with our data as well, where more recently, our phase 2 evaluations or intracranial EEG evaluations did comprise of approximately a third of our entire cohort. Just to touch a little bit about intracranial EEG implantations, there's really two main techniques: subdural grid electrode implantations versus SEEG. Subdural grids do offer contiguous arrangement of electrodes over a large area of the cerebral cortex, and it's done after craniotomy. And it offers high density coverage of key eloquent cortices for extensive functional testing and mapping with cortical stimulation. And it consists of us putting a grid right over the surface of the brain after craniotomy, obviously closing the incision, waiting for the patient to have seizures, potentially performing functional mapping before taking the patient back to the operating room for a second stage of their surgery, which includes removal of all the electrodes in addition to oftentimes the seizure focus. Now, SEEG electrodes offer a more minimally invasive technique of multi-contact intracerebral electrodes for 3D sampling of the seizure onset zone. And it consists of us making small little scalp stab incisions, very small openings in the skull, piercing the dura, and inserting EEG electrodes that offer this 3D evaluation and sampling of the seizure onset zone. And frequently, we will consider SEEG electrodes, especially if functional mapping is less important, or there are more deeper areas that we want to sample, or sometimes with bilateral seizure areas of seizure onset zones. So although intracranial EEG implantation surgeries were not considered, as I mentioned, independent surgeries in this analysis, we did evaluate their trend over time. And the use of intracranial EEG monitoring, including presurgical subdural electrode implantation or SEEG implantation, have decreased in the late era. In the early era, two-stage procedures involving subdural implantations followed by surgical resections comprise of 50.1% of all procedures performed. That is to say, half of all patients who underwent some surgery had implantation with subdural electrodes to assess seizure onset zone or to perform functional mapping prior to resection. So that's a significant bulk of our patients. However, in the late era, the number of implantation procedures decreased to approximately 33.2%, or about 1/3 of all cases. Not surprisingly, the number of extraoperative electrical cortical stimulation mapping, or ESM, declined in parallel to this decrease in implantations. And when our center introduced SEEG implantation in 2015, it has become an increasingly employed tool for intracranial EEG sampling. And in recent years, the number of SEEG implantations have surpassed the number of subdural implantations in our center. So that is to say, the number of intraoperative electrocorticography cases have also decreased to involve only about 77% of cases in the later era compared to about 93.2% of cases in the early era. the number of subdural electrode implantations and SEEG implantations, as well as the use of intraoperative ECOG, definitely decreased in the later era. And I think this largely reflects on the improved pre-surgical evaluation of surgical candidates nowadays, including our center's introduction of the SPECT in 1994, PET in 2005, and now selective use of MEG, TMI, and ESI. So the improved preoperative characterization really allowed for improved localization of the seizure onset zone and the opportunity for more tailored approaches, leaving more of the cerebral tissue intact and decreasing the number of phase 2 subdural electrode implantations. And implantation is now really frequently guided for the need to map eloquent cortex, to do direct stimulation mapping for and that's usually the goal and the reason to perform these implantations for our subdural electrodes. Now, looking at our case mix over a 30-year period, as I mentioned previously, bigger surgeries, so larger volume surgeries such as hemispherectomies, lobectomies, ultralobar resections or disconnections have all decreased proportionately in the late era over the past couple of decades. Whereas focal resections, including lesionectomies, corticectomies, and MR-guided laser interstitial thermal therapy have increased in the late era. Over the past 2 decades, we really introduced many new technologies, including MR-guided LIT, MR-guided focused ultrasound, vagus nerve stimulator, which is a neuromodulation technique, and RNS, which is another neuromodulation technique. And I'll briefly touch upon these more novel procedures. So first of all, looking at MR-guided laser interstitial thermal therapy, I think this is widely used in not just the pediatric world, but also definitely the adult world in both neuro-oncology in addition to functional neurosurgery. But just to give everybody a bit of a background, it is basically entails destruction of a target tissue via delivery of low voltage laser energy through a fiber optic catheter. The surgeon controls thermal injury by MR thermometry, which is real-time monitoring of tissue ablation. And the goal is to precisely deliver a laser with great accuracy to create thermal injury within the lesion and to maximize cytosol reduction and minimize surrounding neurologic injury. What we have seen is that oftentimes it leads to lower complication rates compared to open resection for appropriate candidates. And it allows us to access deep and difficult locations with minimal incision on the brain. Compared to open surgeries, it tends to be a little bit more minimally invasive. There's typically no ICU stay, at least at our hospital, and only about 1 to 2 days of hospital stay. There's earlier return to work or school, and frequently reduced post-operative pain, analgesics use, and also possibly due to patient preference, due to improved cosmesis of a much smaller incision compared to a bigger resective surgery. The first MI-guided LIT surgery case was performed at Nicholas Children's Hospital in 2011, and today we've performed about more than 70% of cases. Some of our preliminary data have been published in 2014, I believe, which was our first small surgical cohort of our initial patients, and then more recently as a part of a multi-center study looking at MR-guided LIT compared to open surgical resection. Vagus nerve implantation is a bit of an older technique now, but it was introduced in 1998 here at Nicholas Children's Hospital, and basically is a neuromodulation technique. The device is implanted in the neck and the chest, and it allows the device to send pretty regular, mild pulses of electrical energy to the brain via the vagus nerve, allowing for seizure modulation. And it was FDA approved for focal and partial seizures in children greater than 4 years of age. We have performed about 102 VNSs in total over this period of time, and the mean age at surgery was 13 years. However, we did perform a handful of VNSs for patients less than 4 years of age and have found quite good outcome in this small surgical cohort. I believe the youngest patient that we have performed VNS for was 18 months of age. And although we do indicate that the FDA approval is for 4 years or greater, this is not a deterrent for us implanting VNSs. We were the first center in Florida to insert Incentiva generator in 2017, which has shown improved seizure control due to heart rate detection, prolonged battery life, and the number of VNSs that we have inserted for patients with both focal and partial seizures have definitely increased over the past 2 decades or so. Responsive neurostimulator is another neuromodulation technique, and it includes implantation of intracranial electrodes to monitor seizures, to detect unusual epilepsy electrical activity, and perform a response to the seizure through pulses of stimulation. It's used for focal seizures in eloquent, unreceptive cortex, and more recently in our centers, thalamic RNS as well. The first RNS implantation at Nicholas Children's Hospital was performed in 2008, and as a part of the pivotal trial, which gave evidence for efficacy of RNS implantation. And we've performed about 7 RNSs as part of the pivotal trial. So those were all adults, and then followed by more than a dozen implants between 2018 to 2022. So to date, we've performed about more than 20 RNSs, making our center really one of the largest centers of RNSs in the pediatric world, at least. This is a case of an adolescent male who performed RNS implantation for the sensory cortex, for seizures. So this is an adolescent male who presented with focal seizures at about 15 years of age, and is characterized by goosebumps, left facial pulling, left arm held tightly against the chest. And he did undergo resection, but continued to have daily left arm sensory motor seizures. And finally, a couple of years ago, he did finally underwent a placement of an RNS and what we thought was the sensory cortex. And he's had significant seizure improvement since then. More recently, over the past few months or so, our center has also started performing thalamic RNSs, and we remain one of the few pediatric centers who have performed thalamic RNS stimulation for an implantation for the pediatric population. So over the past 4 months or so, we performed 3 thalamic RNS placements. And our typical protocol is that we perform a 3T MP2 RAGE sequence that allows us to directly assess the location of the CM nucleus. Our radiologists are able to correctly and accurately point to the location of the CM nucleus for us. And we've only targeted CM so far. So after performing these sequences and targeting the central median nucleus, we proceed to implantation of the RNS, and all 3 procedures have been done using ROSA so far. So as you can see here on the left, you see a patient with, it's a 17-year-old boy with bilateral perisylvian syndrome. So he has multiple areas of polymicrogyria in bilateral areas of his frontal temporal cortices. And this patient actually underwent a VNS, which led to just a little bit of improvement, not significantly, and followed by SEEG implantation. What we found on the SEEG is that the majority of the seizures were coming from the right side, and were quite diffuse, involving multiple areas of the temporal area, particularly, but also in the frontal parietal areas as well. So following quite extensive discussion, we decided to perform a right-sided RNS for this patient, targeting an area of polymicrogyria that had the greatest electrographic activity on the SEEG, which was the temporal lobe, in addition to an electrode in the thalamus on the right side. This patient is now almost 5 months following surgery. He's doing extremely well with more than 90% reduction of his seizures, despite multiple courses of failed medications, ketogenic diet, and VNS. So I think he's doing very well so far. We've also performed 2 bilateral thalamic RNS insertions for patients who are teenagers. We have a 13-year-old and a 14-year-old who recently underwent bilateral CM stimulation in the thalamus. And they're both doing quite well right now. And again, we choose to do the MP2 RAGE sequences, identify the CM nucleus, and assess and obviously assess the candidacy for this type of procedure during Comprehensive Epilepsy Conference with significant multidisciplinary discussions and input from the neurologists. MR-guided focused ultrasound is another very new and interesting procedure that we have started offering as part of a trial. And we have targeted anything as small as about 1 millimeter or anything as large as about 10 millimeters or so in diameter. And the background and the foundation for the study was really from a New England Journal of Medicine trial, which was a thalamotomy procedure for essential tremors in the adult population with a mean age of 71. So in that trial, there were 76 participants, and there was a 3-to-1 randomization of focused ultrasound versus sham procedure, which carry no acoustic energy. And what we saw, what they saw in this paper, in this randomized controlled trial, which is eventually published in New England Journal of Medicine, was a reduction of hand tremors in the patient who did receive focused ultrasound. So it's a very non-invasive technology. It's completely incisionless, and it allows the neurosurgeon to apply ultrasonic energy that is translated to heat to target deep-seated lesions with real-time MR visualization and feedback. And compared to something like, for example, radiosurgery, there's no radiation and there's immediate result that can be seen on the MRI, and we can control the amount of thermal energy applied in real time. The limitation is that it's mainly effective towards the center of the skull, and it's not yet FDA approved. So we are performing these type of procedures as part of a clinical trial. So this was published in 2017, but this was when we performed Dr. Radigan actually more accurately performed the world's first focused ultrasound surgery for hypothalamic hamartoma in a patient with epilepsy. And this is a part of a clinical trial called Feasibility Safety Study of Benign Centrally Located Intracranial Tumors in the Pediatric and Young Adult Subjects. And what we've done so far is recruited patients with centrally located benign WHO grade 1 tumors that require some type of clinical intervention. And the patients are between 8 and 22 years of age, and there's 3 different age incremental groups. So we start off with the older group first, and then we gradually decrease the age for whom the focused ultrasound is being offered. The patients need to have a head circumference greater than 52 centimeters and need to be a little bit older in order to fulfill the requirements of the skull density ratio. It's an ongoing trial. This started in March 2017. It is still ongoing, and we've recruited 5 patients so far, and 3 of those patients actually had seizures. 4 of those patients had seizures, 3 of whom had hypothalamic hamartoma. So as a part of this MR-guided focused ultrasound trial, which was recently published in JNS in January, I believe, this year, 4 of the 5 patients had hypothalamic hamartoma, which is a centrally located WHO grade 1 lesion. And in this cohort, One adolescent female had hypothalamic hyperphagia, while 3 of the 4 patients with hypothalamic hamartoma had seizures. So as you can see here, this is one of the illustrated cases of one of the first patients who are a little bit older. As I mentioned to you previously, this trial is recruiting patients between 8 and 22 years of age. However, we're starting with patients who are older first in the older cohort and gradually decreasing on the age of candidates. So this is a 22-year-old female with a history of gelastic epilepsy. She did undergo transcortical emigrated lit 2 years prior to presentation, so at 19 years of age. But however, there's a pretty clear residual hypothalamic hamartoma and gliosis. What happened was that the patient underwent MR-guided focused ultrasound aiming at thermal disconnection. She underwent the procedure with no complications. She was discharged home post-operative day 2, short steroid taper. She had no metabolic or endocrine or cognitive abnormalities, new abnormalities after the procedure. And over time, over the past 5 years or so, we've seen a sustained greater than 95% seizure reduction in this patient. Similar effects were seen in the 2 of our other hypothalamic hamartoma patients, one of which was, I believe, a 15-year-old male and another who was a 21-year-old female. So what we've seen in these patients with gelastic seizures from hypothalamic hamartoma is that they respond well to MR-guided focused ultrasound. They don't, none of the patients in our cohort had any new metabolic or endocrine or neurocognitive abnormalities. And all of the patients who had seizures from hypothalamic hamartoma have led to a significant reduction of seizure burden over this period of time. Now, lastly, I know that I want to be a little bit cognizant of the amount of time that we have, but lastly, I do want to talk a little bit about our evolution of our 2-year seizure outcomes by Engel classification over the past 30 years. Now, I understand this is a pretty difficult topic to talk about simply because the number and the type of cases and the surgical case mix has significantly changed over the 30-year period, as I have mentioned previously. I do believe that our surgical cohort is becoming more and more challenging. They are becoming more older in age. Furthermore, there's a greater proportion of redo cases, and the number of cases and the type of cases have significantly changed. But if we just look at crude numbers and 2-year post-operative Engel scores, we have this data. So 2-year post-operative Engel classification scores and outcomes were available in about 76% of the entire cohort. And favorable outcomes, defined as at least 50% seizure reduction, is quite high in both eras, at 76% in the earlier era versus 80% in the later era. And what you can see here on the right over here is you can see over here is a greater and more detailed breakdown of the 2-year seizure outcomes captured in both eras. The probability of seizure freedom was quite comparable between the 2 eras, about 54.7% in the late era versus 54.3% in the early era, despite advances in pre-surgical evaluation, intraoperative electrostimulation. And this is most likely a result of increased complexity of the surgical case mix for the reasons I have previously mentioned. When we further segregate the surgical cohort, we observe a much higher chance of seizure freedom amongst patients who undergo first-time surgery in the later cohort, and that increases to be about 57% seizure freedom. I think those numbers are quite favorable compared to other numbers that have been published in other from other level 4 centers, simply because of the more difficult complexity of the case mix that we have performed surgery on, but also since we included our patients who have palliative procedures. So some of these patients who go into surgery are not expected to be seizure-free after surgery. We want to reduce the number of seizures and the seizure burden, improve their quality of life, and improve the neuropsychological outcomes and cognition. But sometimes complete seizure freedom was not the goal in these surgeries. But I think we can confidently say, even when we look at the conglomerate of our patient surgical cohort, we do have a very high chance of seizure improvement and a very competitive chance of seizure freedom at 57% in new first-time operated patients. So in summary, this is data that I'm presenting from an evaluation of an evolution of a level 4 comprehensive epilepsy program over a span of 3 decades. Over this period of time, epilepsy care has definitely advanced over this period, and many pre-surgical evaluation tools that were rare in the early era became more commonplace in the late era, and that includes things like SPECT, PET, MEG, ESI, TMS, etc. As such, the comparison of care over this long period of time are really necessary to best understand how these advances impact surgery and surgical case mix and epilepsy seizure outcomes. Notably, when we look at when we dichotomize these 3 decades into groups of early versus late era, each having 15 years, we do understand that there is a substantial increase in surgical case volume by about 50%, from 453 cases in the early era to about 675 cases in the late era, really reflecting the program's growth. And this parallels other studies in literature that describe an increase in the number of indication of surgical procedures over the past decade. When we look at patient demographics, in the late era, the age of seizure onset was substantially older by about 1.5 years. And to our knowledge, there's been really no significant shift in population demographics and epilepsy incidence that would favor an older age. So interestingly, though the age of surgery was higher in the late era, the duration between epilepsy onset and epilepsy surgery was unchanged. And there has been multiple recommendations over the past decade to expand access to epilepsy surgery and attempt to perform it earlier and with shorter duration of epilepsy, as it is generally correlated to better surgical outcome. So I think as more centers are performing epilepsy surgery, the case complexity in our level 4 surgical center seems to have risen significantly. And some patients that were surgically managed elsewhere, because some patients were managed elsewhere when neurophysiology or neuroimaging was regularly concordant. There's a variety of different factors that's been reported in the literature that influence the delay in surgical intervention, and that includes number one, perception of epilepsy surgery as the last resort for some families. Number two, the desire to maintain therapeutic relationship for one's own patients, then to refer, and number three, to later presentation of epilepsy centers due to the increased number of centers offering epilepsy surgical care, and number four, evolving surgical techniques such as MR-guided lit or RNS that now allow some patients to be candidates for a procedure when prior evaluations would have excluded them. And what we've seen is that advances in pre-surgical evaluation have really shifted the candidacy for epilepsy surgery and surgical technique. And in our two cohorts, the distribution of MRI substrates were statistically unchanged, and the majority being focal lesions, followed by MRI negative cases, broad malformations, and lastly cerebral insults. And during the time course of these two eras, utilization of advanced early techniques to characterize the epileptic network have become readily available at our site, including things like metabolic neuroimaging studies, neurophysiologic source imaging, navigated transcranial magnetic stimulation or TMS, and then advances in MRI, functional MRI, and DTI. So I think over the past 30 years, there's been a significant improvement in our evaluation of patients for surgery. As I mentioned previously, the number of subdural implantations and SCEG implantations is part of phase 2 evaluations, in addition to intraoperative ECOG, have all decreased in the later era. And this really reflects the improved pre-surgical evaluation of surgical candidates, including our center's introduction of SPECT in 1994 and then PET in 2005. We also use things like MEG, ESI, TMS, as I mentioned previously, all very selectively. And the improvement of preoperative characterization also allows for improved localization of the seizure onset zone, the opportunity for more tailored approaches, such as small volume corticectomies or focal resections, leaving more of the cerebral tissue intact. And implantation is now frequently guided for the need to map eloquent cortex or to perform a direct stimulation mapping. And lastly, as we look at surgical case mix, as I mentioned previously, there's been a much greater emphasis over the evolution of the 30 years to focus on focal resections and corticectomies, in addition to a focus on neuromodulation techniques. And this reflects our program's emphasis on the preservation of function. And notably, the number of focal resections, corticectomies, lesionectomies, and guided LIT procedures have increased over time, and more extensive procedures like hemispherectomies, multilobar resections, disconnections, and lobectomies have all decreased. And in the past decade, our program has embraced these technological advancements that include introduction of LIT in 2011 and MR-guided focused ultrasound in 2017. As part of a larger clinical trial. And lastly, we have introduced VNS and RNS to our surgical repertoire, and I think RNS has really increased over a period of time. And especially when we include our pediatric RNS cohort in a recently published multi-center retrospective analysis, we do see that RNS does show improvement and significant efficacy in this patient cohort in a carefully selected patient population as young as 3 years of age. So as a level 4 center, really the complexity of surgical cases have increased over time, and evidenced by increase in the number of repeat surgeries and older age at surgical intervention. However, our surgical success by Engel classification have remained stable over the two eras, and the probability of seizure freedom is quoted to be approximately 55 to about 57%, which I think is quite favorable. So thank you again for allowing me the opportunity to speak today about functional epilepsy surgery, and specifically about our program at Nicholas Children's Hospital. My email is included. Please feel free to contact me if you have any questions or if you want to learn more about our program. Thank you.
Thank you, Dr. Wang.
Hi, Shelley, is Howard Landy. Great talk. That was wonderful. I have one question with this large variety of techniques. Was there any use of multiple subpial transection?
It's a great question. I don't think so. And if at all, it probably was older data, but it was not, that technique was not something that really stood out in our program. And for me, I've been here for about 4 years. We have not performed multiple subpial transactions here over the past few years' time.
Howard, Glenn Morrison, we did try a couple, they just didn't work.
Perfect. Thanks so much for jumping in, Dr. Morrison.
My experience was a grand total of 2 cases in adults, and it worked very well to my great surprise. So I was just wondering if you would use them.
No, I don't think, at least in recent years, we have done them. Dr. Morrison, you probably did them at least 10 years ago, right?
Maybe 20 or 30, Shelley, but yeah.
Yeah.
Well, Howard, maybe the difference is adults versus kids, but we did try a couple, and
Right.
and as you well know, the literature does not speak well of them. There was a transient enthusiasm, but transient.
Yeah, my conclusion was it has to be very selected cases, which is what ours were.
Right.
Great, thank you
Perfect.
so much.
Thanks for that great review, Shelley. Maybe since you got a couple of minutes, you can tell us what the future of epilepsy surgery holds and where you think we're going to go in the future.
I think that's a great question. I think there's going to be a lot more neuromodulation and more and less invasive techniques. There's also a lot of interest in multi-center collaboration, looking at pooled data and looking for biomarkers, for example, for improved seizure outcomes, for example, with neuromodulation techniques. And then lastly, I think there's going to be a lot of enthusiasm for, as I mentioned, procedures that preserve function. And we're really heading from larger volume surgeries, as I mentioned, hemispherectomies, to smaller volume procedures like MR-guided focus ultrasounds or MR-guided lit or more focal resections. I think it's a very exciting time for functional neurosurgery right now because of the number of collaborative efforts between different hospitals, and also as a part of our program, as well as many other programs, the introduction of things like machine learning into pre-surgical evaluations to assess for selection of surgical candidacy.
So do you think the changes in the future are going to be driven by technique, surgical technique, or by the pre-surgical evaluation, or a balance of the two? Where do you think the big changes are going to be in the future? Where should we be focusing our attention and our interest?
I think it's going to be a balance of those two, but I think it's probably going to be more lenient towards pre-surgical evaluation, identifying the patients who will enjoy better outcomes and improve better success from epilepsy surgery.
I think it's going to be exciting to watch as our ability to evaluate pre-surgical patients who are refractory to medications, and we learn better how to understand the epileptic network that is the source of the child's epilepsy. And instead of focusing on where the seizure begins, at least on the surface, we focus on its pattern and its networks, because when we fail, even though we've taken out the focus, we're missing something, right? So anyways, thanks for a great talk. Well, you could pick any one of those topics and spend an hour on them, but you did a great job with all this effort. So huge amount of effort on Shelley's part, and thank you for doing it.
Thank you so much. Have a wonderful day, everyone. Thank you.
Good morning. Thank you for having us this morning. We do have some compliance topics for you today. We've invited Becky Jacobson from Panacea. She'll be facilitating this morning's session. She has her slides ready. So my name is Ifis Matute. I'm the Director for Educational Initiatives for UHealth Compliance. And we're here today to share some of the new information that's available to you regarding coding, billing, and documentation. The session is being recorded, evidently for your benefit and for the benefit of your peers that may not have been able to attend today's session. And of course, for your residents and fellows that are either joining already or soon to be joining. We ask that if you have any questions throughout the session, please place them in the chat. This will allow Becky the opportunity to cover as much material in the allotted time. I assure you that the questions will be answered between the sections or at the end of the session. Also, if you have any additional questions after the session, feel free to send them to us to complianceeducation@miami.edu. We'll be more than happy to respond to them as they come in. Also, if you feel the need of having a one-on-one session or more information that you want regarding billing, coding, or documentation, feel free to ask. Compliance is here as your partner and your resource. We're here to help you. Also, as you can see in the background that I have today, our annual compliance program training is on on its way. It's a mandatory requirement, not only for Medicare, managed cares, but we're also under a corporate integrity agreement, which strictly requires completion of these compliance trainings. So if you haven't done so, I encourage that you do so at your earliest convenience at ulearn.miami.edu. And if Becky is ready, we are ready for you.
I think I'm ready. Can you hear me?
Thank you. Yes, Becky, thank you.
We can hear you, but
Awesome,
we
and you
cannot
see
see
my
you.
Oh, yeah, you don't want to see me right now.
Oh, okay. Just making sure.
Ivis knows I'm an hour behind you. I am in Wisconsin. So this is prior to my original start time that I usually am working, but we veer away from that quite frequently with these sessions. So good morning, everyone. You're coming off of an exciting topic, and I will try to keep it exciting for you. We're going to go through some updates today. One of the first things I want to talk about is the disclaimer. So everything in the presentation is based off of Centers for Medicare and Medicaid Services, or CMS, as well as the American Medical Association, or AMA. What we're going to go through today for our agenda, talk about neurostimulators, posterior tibial nerve, spinal deformity coding, and then we're going to get into some teaching physician guidelines, shared split care. There are some changes there. And then we're going to talk about evaluation and management in several different settings, as well as at the end, some modifiers. So jumping right in to the posterior tibial nerve neurostimulators. We have some temporary codes out there for these services. So a lot of providers often say, I never used temporary codes. We like you to use temporary codes when the descriptor of the procedure matches exactly what you're doing. The reason is if we don't use temporary codes, we're never going to get a permanent payable CPT code. So we're looking to transition those temporary codes into permanent codes that have RVUs attached to them. These temporary codes are typically based, payment for them is payer based. So it varies from payer to payer what they're going to pay on them. So this 0587T is for the implantation or replacement of an integrated single device neurostimulation system. So what this includes is the array and receiver or pulse generator, the analysis of that, the programming and imaging guidance when it is performed. You can see with the temporary codes here, we have some do not reports. So you cannot report those codes along with the 0587T. They would be bundled and we can't unbundle them. When we come to the revision or the removal of that neurostimulation system, that is 0588T. That again includes the array, the receiver or pulse generator, the analysis, the programming, as well as imaging guidance if it is performed. And again, the same do not reports with these. So you want to make sure that you're grabbing the correct codes here. For the analysis portion, we have simple programming and we have complex programming. So you can see that there are quite a few different parameters that they're looking at. For simple programming, it is 1 to 3 of those parameters. Now, this analysis has to be performed by a physician or other qualified healthcare professional. An other qualified healthcare professional, physician assistant, or a nurse practitioner. But for the simple analysis, you need to have 3 of those areas documented there, those parameters. This is set to sunset in January of 2025. And at that point, they will then reevaluate the usage of this temporary code to determine if we should make a permanent code for it. The complex programming, same thing here, except you have to have 4 or more parameters. So same thing, you really need to, for the analysis portion, pay attention to, you know, your documentation and make sure that you're getting, you know, 1 to 3 or 4 or more really documented specifically for us to get these in the correct category for the code. Spinal deformities. A couple of updates here. One of the things that we often have issues with for spinal deformity, the arthrodesis procedures, is the documentation. You really want to make sure when you're looking at these, when they say a segment, a vertebral segment, it's the complete vertebral bone, any articular process in the lamina. So your documentation is key. In order for us to get the correct number of vertebral segments, we're really looking for C3, C4, important with any spine surgery, the difference between putting a comma after your level versus putting C3 C4, okay? So really want to make sure that when we're talking about spinal deformity, we're really getting the commas instead of the dashes in between, because each one of those would count as a vertebral segment. With these codes, bone grafts and internal fixation devices are coded in addition to the arthrodesis codes. So here we have the anterior arthrodesis, again, talking about those vertebral segments. So make sure that you have your commas in. And again, the bone grafts and internal fixation devices are coded in addition to these. Kyphectomies, again, segments. So want to be careful with the documentation here. This is for a circumferential exposure of the spine and resection of vertebral segment or segments. Now, look at the parentheses here, including body and posterior elements. Again, this comes down to your documentation. We want to make sure that in your documentation, we're seeing something about the body and the posterior elements. With these two codes, you cannot report the vertebral body tethering codes, which are temporary codes. So we shouldn't be reporting those separately with any of the spinal deformity codes that are out there. Talk about teaching physicians from an E&M perspective. 2022, we had an update, and I think for the majority of us, we have always considered any resident or fellow time alone with the patient as a non-billable service. If what they've clarified in 2022 is if you're using time for your level of evaluation and management service, only the time that the teaching physician is present can be counted. So resident and fellow time alone does not count here. When we talk about the documentation for attestation statements, there's a couple of things. We do need 2 bullets documented. The first one is the teaching physician's participation in the management of the patient. The second is, were you present during the key or critical portions with the resident or fellow, or did you perform those at a separate time from the resident or the fellow? That also needs to be documented. So your face-to-face time, whether it was just with the patient or with the resident and fellow, and then your management in the patient, your participation in the management of the patient. You must document your own attestation statement. You can use a macro, or you can manually add that to your note by typing. Have some slides here. The first one is acceptable documentation for attestations. You can see that they aren't real long, but they do meet the guidelines for both of those areas being addressed. And then when you look at the unacceptable, that's a little bit shorter and sweet, do not meet the guidelines for an appropriate attestation statement. Late night admissions. When the patient, this is the only time that you and the resident or fellow can see the patient on separate dates of service, is when the patient is admitted late at night. So patient comes in and is admitted to the hospital at 11:30 p.m. The resident or fellow documents a beautiful H&P for you and sees the patient, develops the plan of care, probably calls someone to discuss that patient. When you come in the next day, the next morning, you come in at 7:30 in the morning and you see the patient, if you can use the resident or fellow's documentation from the night before for your initial admission. A couple of things. You have to document that you saw the patient and the date that you saw them, because that is the date that we use to bill. You have to document any changes in the patient's condition and clinical course. So an example here on the bottom, I saw and evaluated the patient. I reviewed the resident's note from, that's going to be the night before, and agree with an exception. So that would be an appropriate attestation statement. That will lead the reviewer or the coder to go look at the resident's note and use that towards the level of service as well, but only applicable in late night admissions. For surgical services, teaching physician guidelines, we have minor procedures, endoscopies, and surgical high risk and complex procedures. So you hear us talk quite frequently about global postoperative periods. Those don't apply to figure out if it's a minor procedure or a major procedure. What we're looking for here is the amount of time that it took to perform that particular procedure. So for teaching physician guidelines, a minor procedure is considered one that lasts 5 minutes or less. For that procedure, the teaching physician must be present during the entire time of that surgical procedure. For these, we do recommend that you document the time. That leads us to the correct attestation statement that we're looking for. Endoscopies, you guys probably don't do a ton of these, but you have to be present during the entire viewing, and you have to be standing side by side. You can't view from another room. For those surgical, high risk, and complex procedures, which is typically what neurosurgery is doing, the teaching physician must be present during all critical and key portions of the procedure, as well as immediately available to furnish any services during that procedure. So attestation statement, I was present during the critical and key portions of the procedure and immediately available for the entire procedure. That is what would suffice there. Key and critical portions of the procedure are not defined. That is up to the discretion of the teaching physician. For overlapping surgeries, if it's a single surgery and you're present for that entire procedure, your presence can be documented either by you or by the resident or fellow. So they can just state, you know, Dr. So-and-so was present for the entire procedure, and that will suffice. For 2 overlapping surgeries, you have to be present for the key and critical portions of both of those procedures. So of course, those key portions can't take place at the same time. You must personally document that you were present for the key portions of the surgery. However, you may have a covering qualified surgeon. We don't see that happen a whole lot. And then for 3 overlapping procedures, those are not payable under the physician fee schedule. We take the combined entries of the teaching physician and the resident or fellow to determine levels of service and establish medical necessity. Again, there are your unacceptable documentations. For attestation statements, make sure that those are getting documented by you, with the exception of a few little cases in there. I think it's easier for us to teach that you always document your own attestation statement. And again, make sure that you date and sign and your attestation statements when you add them. Shared split care services. We had changes to this year. One of the key things to make sure that you know is what place of service is your clinic credentialed as. If it is place of service 11, shared or split care no longer applies in that setting. It is only allowed in the facility setting. Shared split care is when you're both seeing a patient, that would be a physician with a PA or an NP on the same calendar day. These are allowed in outpatient clinics that are provider-based or just outpatient, credentialed as an outpatient clinic. Those are place of service 19 or 22. Allowed in the inpatient setting, observation setting, emergency room, for all prolonged care services, nursing facilities, as well as critical care. It doesn't matter if the patient is new or established. And then one thing to always keep in the back of your mind, consultations or mandatory nursing home visits cannot be reported as shared or split care visits. So when we look at these now, the documentation has to identify both providers that perform the visits. We combine the documentation together, but report only one E&M. So who do we report it under? If the encounter is billed based on time, it is the practitioner who has greater than 50% of the total time. If it is the key components, we are looking that the substantive portion can be either the history, the exam, or the medical decision-making, but it must be documented in full by the billing practitioner. So recommendation here is if you're using the key components, the nurse practitioner, physician assistant would document the history and the exam, the physician would come in and document the assessment and plan, and then we would bill under the physician. The practitioner providing the substantive portion must sign and date the note. However, we always recommend that whoever documents sign and date. So not a bad idea if you both do. And these shared or split care services now require a new modifier, F as in Frank, S as in Sam. So one thing I want to say from experience, I've been in this industry over 25 years. Whenever they give us a new modifier, they're going to watch it. 9 times out of 10, it's going to end up in an OIG or a RAC audit. So you want to make sure that you're really getting these guidelines down straight. Now, that being said, January 1st, 2023, the guidelines for these services are changing again, and all split shared visits are going to be billed based on time. So each practitioner is required to document their time in addition to what services they provided. The time is added together for the level of service, and the practitioner with greater than 50% is going to be the billing provider. So really want to make sure that we're getting time appropriately documented, and also keep in mind that we can't bill twice if your minutes overlap. So a recommendation going forward, starting January of 2023, is that you document your actual time. So like nurse practitioner was, 5:05 to 5:18, physician was 5:25 to 6 p.m. So if you overlap minutes, we can only count each minute once, just so you're aware of that. So we're going to go through the new guidelines that came out January 1st of 2021. in the clinic setting, I have some exciting news. It was released yesterday that the guidelines come January 1st, 2023 for evaluation and management services are all going to be following these guidelines that we're talking about right now. So I'm sure you guys are going to get an education session because there are codes that are deleted. There are codes that are added. Descriptors have changed. And of course, the guidelines have changed significantly as well. So for right now, in the office or other outpatient setting, for 2022, this 99211, which is technically a nurse visit, they deleted from the descriptor, usually the presenting problem or problems are minimal. And that is because their intent is to remove all references to the presenting problems, especially with this code, medical decision-making doesn't apply to 99211. So from an E&M perspective, if you are going to be selecting your level of service based on time, hopefully by now you have gone away with the, total time, X amount of minutes, greater than 50% was spent in counseling and coordination of care. That is no longer necessary for these particular office or other outpatient codes. Your documentation must reflect if a separately reportable service is being billed on the same day as the E&M, documentation must reflect that your total time excludes procedural time. This does include time spent by the physician or other qualified healthcare professional, both face-to-face and non-face-to-face on the same date of service. However, your time does not include any ancillary staff time, so that would be for your nurses, your medical assistants, etc. Here are the time ranges for each CPT code that we have in this area. One of the things that I want to say about this is they are looking for your specific number of minutes. Now, that being said, we know that you don't walk around with a stopwatch, but we have seen some providers that are putting 60 to 74 minutes was spent with this patient. We're seeing approximately 60 minutes. Okay, that's not what they're looking for. They are looking for 35, 45, 65 minutes. So the exact number of minutes for these. If you are not using time, we then default to medical decision making. So we have the 4 levels of service, level 2, 3, 4, and 5. It does not matter if the patient is new or established. For medical decision making, we have 3 different elements, and our final code selection requires 2 out of the 3 elements to be met. So our first element is the number and complexity of problems addressed during the encounter. You can see I have some red on this slide. For every item that you have listed in the assessment, you should have a plan documented. That shows that you have addressed each one of those problems listed in the assessment. Without that, we don't know that you actually addressed each one of those conditions. For the amount and/or complexity of data to be reviewed and analyzed, the days of copying and pasting diagnostic test results into the note without any further documentation is not going to suffice for showing that you analyze that data. So we need to show or add a sentence, labs reviewed, and what did you find? Were they normal? Was something elevated? What are you going to do with that information after analyzing it? The third one is the risk of complications, morbidity, or mortality of patient management decisions made at the visit. So for this, it's important that you document if the patient has several different treatment options and you sit down with them and you outline 3 or 4 different treatment options. And after shared medical decision making with the patient, they have then decided to go with X. We still will assign risk to all the treatment options that were discussed. So after shared medical decision making, the decision may be that the patient try maybe over the counter or prescription medications, but a major surgical procedure was also discussed. The risk is still going to count for that surgical procedure because it was discussed. It doesn't mean that you have to necessarily, that needs to be the treatment option. I hope that makes sense. For that first bullet, complexity, for each of the levels of service, they outline what types of problems fit into each one of those categories. So I think that straightforward one for the level 2 is those are self-limited or minor problems. Typically, the patient could have called mom, and mom could have gave the answer to that question. So probably not going to see those alone. They're typically part of a larger, more complex visit. For level 3s, we have 2 or more of those self-limited or minor problems, one stable chronic illness, or an acute uncomplicated illness or injury. And I want to tell you what the descriptor of acute uncomplicated is. That is a problem that either with or without treatment runs a low risk of long-term repercussions for that patient. So keep that in mind. We end up putting a lot of itises in this category. Level 4s, 2 or more stable chronic illnesses, 1 chronic illness with exacerbation, progression, or side effects of treatment, undiagnosed new problem with uncertain prognosis. So the patient comes in with lumbar pain and they walk out with lumbar pain, and you're ordering a bunch of diagnostics to try to figure out, what's going on with that patient. That's undiagnosed. An acute illness with systemic symptoms, or an acute complicated illness or injury. When we get to that level 5, difference here between level 4 and level 5, that chronic illness for a level 5, it has a severe exacerbation, progression, or side effects of treatment. We are looking for very specific documentation to tell us the severity of the side effect, progression, or exacerbation. The other one that fits in a level 5 is that acute or chronic illness or injury that poses a threat to life or bodily function. For data, what we're looking for data here is work. It's really, what are you doing from a work perspective? So for level 2s, we don't really need any data reviewed or analyzed. For level 3, we have 2 different categories. The first is tests and documents. So each unique test or document counts. Tests. If you are ordering 2 lab tests, make sure you document which ones. A CBC and a CMP are 2 unique tests. The same thing with documents. Medical records being reviewed from hospital A and hospital B are 2 unique sources. So we're really looking for specificity here to ensure that we can get the correct number to get you to the right level of service in the data area. The second category for that level 3 is assessment with an independent historian. And an independent historian is anyone who gives history in addition to or on behalf of the patient. So make sure you're getting that documented. For level 4s, we now have 3 categories of data, and you have to meet 1 out of the 3. The first is that tests and documents. What has happened here is with that test and documents, that in assessment with an independent historian has moved into the test and document area. So the second area is independent interpretation of a test. This is you physically looking at the X-ray, the CT, the MRI personally, and making your own interpretation of what you are seeing. So my personal review of the MRI shows, and what did you see? Now, if you're separately billing for the interpretation and report, then you can't use it here, okay? Because you're getting paid with that separate code for the RS&I. The third category here is discussion of management or test with an external physician in a different group or specialty and or an appropriate source. So here we're making sure that that management or the test discussion, that provider is in a different group or specialty. For appropriate sources, a lot of times here what we see is if there's, workers' comp involved, if there is, any type of legal services involved here, those types of things. For level 5, we have the same 3 categories as level 4. However, you have to meet 2 out of the 3 categories. So same categories, you just need to meet more. So as you can see, as you move up in levels of service, the amount of work from the data perspective also gets a little more intensive. For risk, what we're looking at here is the risk of complications and or morbidity or mortality of patient management decisions that are made at the visit, the risk that's associated with the patient's problem or problems, and the risk of any diagnostic procedures or treatments that are going to be done. Risk includes possible management options selected and those that are considered but not selected after shared medical decision-making with the patient and family. So here you want to make sure that you're getting all those management options documented, the discussion of them, and then what you're deciding to go forward with after shared medical decision-making. Couple of tips here. The chief complaint is required on all encounters, does not matter place of service. You can be inpatient, observation, emergency room, clinic. We need a chief complaint. For the history and the examination, we're not counting these elements anymore to meet a specific threshold. They are no longer part of the documentation guidelines. What the guidelines say is that you document what is clinically relevant. So what we've seen here is that providers truly are not taking advantage of this. The recommendation is to document what you do for the history and the exam and really focus on your medical decision-making or your assessment and plan. So for that assessment and plan, make sure that you document all your problems that are addressed and treated at the visit. Document using descriptive words, acute, chronic, mild, severe, not responding to current treatment. Make sure you get those descriptive words in there. Document all your studies that are ordered and analyzed. Remember, copying and pasting those results without any analysis is not counted towards your level of service. Document all treatment options, comorbidities that affect your treatment, and treatment goals to demonstrate the level of risk. So summary of changes here, only diagnoses that are receiving active assessment and or treatment count towards the level of service. For complexity and data, that's work. So we have different combinations of work to score that area for medical decision-making. And for risk, what they say here is that risk is determined by the provider and based on the provider's clinical judgment of the patient's overall condition. We do have a table of risk. It provides us examples, but trust me, not everything fits nice and neat into that table of risk. So a lot of times as a coder or a reviewer or an auditor, we're sitting back and we're teetering on the level of risk. if you really want to take the subjectivity out of that risk area, you certainly can document the level of risk within your notes. So after you finish your assessment and plan, underneath that, you could put risk, high, patient undergoing major surgical procedure with comorbidities of, and then list their comorbidities. So, you know, you can, what it's recommended that you document the risk of the patient because it is based on your clinical judgment. So moving from those guidelines that came out January 1st, 2021, in the other settings, we still have the old guidelines, the 1995 and 1997 guidelines. So keep in mind that these guidelines we're going to talk about right now are good and active until the end of this year. January 1st, 2023, everything's going to change over to the guidelines that we just talked about with a few modifications and clarifications. So in the inpatient and observation setting, we still are looking at history, exam, and medical decision-making for your overall level of service. Of course, medical necessity is still the overarching criteria for the level of service, in addition to the individual elements that we need in order to code that. Again, we talked here about the chief complaint. I really want to reiterate this. A lot of times we see the chief complaint not being appropriately documented in rounding notes, whether the patient be inpatient or observation. Because typically what happens in that setting is we switch over to a SOAP format of the note. And the subjective might say, you know, patient did well overnight, sitting up in bed, eating breakfast, no complaints today. And then we have an exam, and then we have an assessment and plan, and we still don't know why you saw the patient. So always start your note off with follow-up of, or patient has a new complaint today of, so that we know the reason why you're seeing the patient. It's very important, especially when we have a lot of different specialties that are seeing that patient and all billing, you know, subsequent inpatient or observation visits. So make sure you're getting that appropriately documented. The slide on medical necessity here, you know, we don't look at the volume of documentation. We actually look at the amount of work and the thought process of the provider in order to get to the appropriate level of service. You know, we do pay attention to the history and the exam in these settings. So we need to ensure that everything documented was medically necessary in order to treat or manage that patient. In the inpatient and observation setting, when I teach, I often focus heavily on the nature of the presenting problem or problems as it relates to medical necessity. So for acute problems, we have 3 different levels of service. For a level 1, the illness or injury is uncomplicated in nature. I really call these, oh, by the way, doctor problems. Typically, they are rolled into a much more complex visit. We typically don't see these alone. For a level 2, we have a complex acute problem that has multiple contributing factors and treatment options. So the key here is to get those contributing factors and treatment options documented. For a level 3, we have an acute, highly complex problem that poses a threat to life and bodily function. So you'll see a consistency in those higher levels of service here. For chronic problems in the inpatient and observation setting, for a level 1, we have a chronic, stable, well-controlled condition. Level 2, we have a chronic problem with an acute exacerbation or 2 or more stable chronic conditions that are managed. And our level 3 is a chronic problem with a severe exacerbation that threatens life or bodily function. So for that level 3, we have to get the severity across as well as the threat to life or bodily function. When we move to outpatient visits, consultations, and the emergency department, we now have 5 levels of service. For those acute problems, level 3, 4, and 5 are exactly the same as levels 1, 2, and 3 in the inpatient and observation setting. So what has been added here is a level 1 or 2. Those are those minimal problems. They're minimal in nature and risk, would have likely resolved without the attention of a physician, typically part of a larger, more complex visit. For chronic problems, again, level 3, 4, and 5 are the same as levels 1, 2, and 3 in the inpatient and observation setting. That level 2, again, is that minimal in nature and risk problem. For discharge services, 2 codes, they are time-based, 99238 and 99239. If time is not documented, the code does default to 99238. For 99239, please make sure, again, you are documenting the number of minutes. We see a lot of documentation here that says greater than 30 minutes was spent in the discharge of the patient. The recommendation is that we switch that to 45 minutes, 50 minutes, whatever it may have been. So try to be as specific as you can with your number of minutes here. The time documentation is physician time only. It must be documented by the physician, so resident and fellow time does not count here. This time, however, is all-inclusive, includes your final examination of the patient, any discussion, any instructions that are given to the patient or caregivers, prep of the discharge record, prescriptions, and referral forms. So it's all-inclusive. Please make sure for discharge services that your documentation supports that you saw the patient face-to-face on the day of discharge. I can't think of a better way than documenting the final examination of the patient within the discharge note. For observation discharge, we have one code, 99217. It is not a time-based service. However, make sure your documentation does support a face-to-face visit on the day of discharge. In the inpatient and observation setting for time, if you're going to be billing based on time, this is where greater than 50% was spent in counseling and coordination of care is still applicable. So we need that. We also need the context of that counseling and coordination of care, as well as the total time. In the outpatient setting, total time is face-to-face with the patient. In the inpatient setting, it is total floor unit time. So if you're at the nurse's station discussing the patient and how they did overnight, looking through the nurse's notes or other providers' notes from the day before, that time is counted towards your total time, but it does not help you get to that greater than 50% for counseling and coordinating care. If the documentation reflects all 3 of these, we then select the level of service based on time. And again, for these, if you are billing for other tests and procedures, you must document that your total time excludes those billable procedures. Here is an example of time-based billing and how to appropriately document such. Emergency departments. If you're called down to the emergency department to render a consultation. Now remember, consultations, you have to have a request, you have to render your opinion, and then the requesting provider has to get that your opinion or advice back. So you can, if you see the patient in the ED and they're not admitted to the hospital, you have 3 options here. You can code your outpatient consultation codes 99241 through 99245. One thing being said, Medicare does not recognize those consultation codes anymore. So Medicare actually says that they want the provider to code an emergency department visit. So they do allow the physician and the consulting provider and the ED provider to both code ED visits. You have to be different specialties. That's the one thing that they say. Or your other option is office or other outpatient visits, 99202 through 99215. What we recommend here, code for what you documented. Okay, if it's truly a consult, code your consult. If it's not, code your ED visits, and on the back end, what I can tell you from working with compliance as well as some of the coders with Miami, you have a very robust and great knowledge base there. They're going to catch those if the payer does not pay for that code, and then they'll look at your documentation and get the correct code out the door for payment. If you see the patient in the emergency room and they are admitted to the hospital and you are the admitting physician, you then would code your initial hospital visit series, 99221 through 99223, with modifier AI. Modifier AI says that you are the true admitting provider. If the patient is seen in the ED and admitted, but you are not the admitting physician, you can code your inpatient consult codes, but you do have to meet the definition of the consult. However, again, Medicare doesn't cover those consult codes. We have to switch those over to an initial inpatient visit. So it gets to be a little bit hairy on the back end here, but trust that there's a good system in place to catch these. For observation, again, if you see the patient in the ED, you admit them to observation, you would bill your initial observation visit codes or same day admit and discharge. If you are not the admitting provider, so you did not place them in observation, you can code your outpatient consultation codes or your office or other outpatient visits, 99202 through 99215. So one of the things I can tell you here, I haven't read through the whole proposed final rule as of yet, but one thing I did notice is that they are getting rid of all observation codes, and the inpatient codes are now switching over to inpatient or observation. So we're going to be getting rid of some codes and bundling them together from a descriptor perspective coming January 1st, 2023. 2023, there's also changes to prolonged care service codes. But as of right now, this is what we have through the end of this year. In the office setting for prolonged services, this is for patients that do not have Medicare. You do need to use time, and it has to meet level 5, new or established. After that, then we do start adding on prolonged care service codes. This is time on the same calendar day as the office visits, and it is calculated in 15-minute increments beyond the minimum time required. So here you can see for an established patient, level 5, in order to add on 99417, you need to have at least 55 minutes documented. And then as we move forward with each additional 15 minutes, our number of units go up on 99417. For prolonged services for Medicare patients, we have a G code. Again, you have to meet the time requirements for level 5. However, for this one, the time is calculated in 15 minutes beyond the maximum required time. So here you can see that you do need to meet the 69 minutes for adding on the G2212 versus the 56 minutes on the previous slide for non-Medicare patients. And then as we keep moving up, we add on number of units. Office or other outpatient services, we have 99354 and 355. So these are services in an outpatient setting, except for office visits. What happens here, these are added on for consultations, outpatient consultations, and that is probably the only thing that would be applicable in your arena. So we choose the primary code based on what your documentation supports. And we take that typical time per the code descriptor in CPT. After that typical time, for 30 to 74 minutes, we keep adding on 99354. And then after that, we do the add-on code 99355 for however many units are supported. In the inpatient and observation setting, we have 99356 and 357. These two codes are applicable for initial and subsequent observation codes, initial and subsequent inpatient codes, admit and discharge on the same date of service, hospital consultations, as well as the nursing facility. Remember that in the inpatient setting, your time is bedside and on the same floor or unit that the patient is on, and it does not need to be continuous. So if you are utilizing time here and you go in 3 or 4 times, you want to make sure you keep adding your time to that note. So here again, the typical time is based on the primary codes descriptor in CPT. And then after 30 minutes, we start adding on the 99356 and then the 99357 as the time increases. Prolonged care services, non-face-to-face. These are reported in addition to other face-to-face services at any level, either that is performed, the E&M is performed either before or after. So we can report these codes on a different date of service than the primary E&M code. So what we're looking for here, we use the time as defined by CPT, the typical time. And then after 30 minutes, we start adding on the 99358 and then the 99359 as appropriate based on your time. Modifiers. Co-surgeons and team surgeons. So when we're looking at this, modifier 62 is for 2 surgeons and modifier 66 is for more than 2. This is if the same CPT code, so the same surgery is being performed on the same patient at the same operative session. So you all have to bill the same CPT code, and then you add the modifier on. If that is not the case, then each surgeon bills independently for what procedures they performed. For co-surgeons and team surgeons, documentation has to be done by each surgeon, and you have to describe your role in the performance of that procedure. So you have to document your own operative notes. For assists, we have modifier 80 for an assist, 81 for a minimum assist, 82, that is when a qualified resident is not available. You want to make sure your documentation, if you have residents and fellows in your surgical teaching area, you want to make sure that if you're bringing in another MD to assist you, that you state that a qualified resident was not available. Modifier AS is for a PA or an NP when they are the assist. Couple of things here. You have to document the assistant's name and their credentials. Okay, this is so we know, are they a PA, an NP, are they a resident, are they a fellow? So, or are they another MD? We need to know what they are. Why is the assistant necessary? That surgical assist has to be doing more than what a surgical tech can do. Okay. So you want to make sure that you're specifically documenting why is that assistant necessary and how did they participate in the procedure. That's the one thing that we typically see that's missing. And a lot of providers come back and say, I don't understand, because when we look at this code on the Medicare Physician Fee Schedule database, it tells us that an assistant is allowed. Just because they're allowed doesn't mean that it's gonna get paid, because what the guidelines say there is a surgical assistant may be paid. It doesn't say will. So you want to make sure your medical necessity for the assist is always, always documented. So if that does get pulled for an audit, we're safe. We've got that appropriately documented. At the end of this presentation, yes, we are nearing the end, I have some reference slides here. These are good until January 1st, 2023. Then everything's going to get switched over here. But for the time being, if you look at the darker teal, these are for initial inpatient and observation codes, or we call them H&Ps. You have to meet or exceed all three areas: history, exam, and medical decision-making. The codes and the typical times are listed on the bottom row. What's important to remember here is, yes, we are still looking for history and exam to meet that threshold. What I urge you to do is to use those slides where we talked about the nature of the presenting problem as it relates to medical necessity, to figure out where your patient would fit from a medical decision-making perspective. Reference these slides to ensure that your history and your exam support that level. If not, you may need to code down one level. Subsequent inpatient observation now require 2 out of the 3. Typically, we use the exam and medical decision-making. If there is a new significant problem that's addressed while you're rounding, make sure you sufficiently document that. We will then typically gear towards using the history a little bit more, because you usually have to go a little bit further in depth for that new problem that you're looking at. Inpatient consultations here, these are 3 out of 3 again. Observation consultations for the provider that is not admitting the patient to the hospital. So your codes and your typical times are at the bottom of this slide as well. I don't see any messages in the chat box. You guys are quiet this morning, taking it all in. But I would like to thank you for your attendance this morning. I hope that you found this helpful. Be on the lookout for some sessions once January 1st rolls around. There's going to be some new stuff coming out with lots of interesting takes in the proposed final rule. So thank you again.
Thank you so much, Becky. That was fantastic. I thank all of you for attending this morning. If you have any questions, again, please feel free. Please make sure to do your compliance training at your earliest convenience. And with that, please have a wonderful day. Thank you.